Thank you very much for the kind introduction. I won't be talking to you about science today. It's a very different topic. It's about academic neonatologists. I'm an academic neonatologist, or a university-based academic neonatologist. I've been one for many decades, and I truly believe that I have the best job in the world. Even better than the Lego master builder who talked to us yesterday. I don't have one job. I have 8 jobs, as you can see. I'm like an octopus. I have different jobs. The job that's most taxing among all that I do is being an administrator or a chair. And what this job involves is balancing faculty from 16 different divisions who work very differently, and all of them have the main issues. How do you balance money, which is very important, and time? So every faculty member wants an optimal balance of reasonable compensation with work-life balance. How to balance these two is what I do on a regular basis. Of all the other jobs I have, my favorite one is being a parent. I have 3 kids, and I really enjoy spending time with them. A close second is being a mentor. I often consider all my fellows to be like my children. As a parent, I really enjoy looking at my children and looking at their achievements and relishing them. Similarly, nothing gives me greater pleasure as a mentor than to see my mentees succeed, than to see my fellows succeed. And the concern I have is that gradually this species of academic neonatology, which I consider to be the best job, is slowly becoming extinct, and I feel like a dinosaur, and I want to talk about that. So let me start off with a quick story. This is a story I hear throughout the country. This is mostly relevant to US-based physicians, but for those of you from Canada and other countries, it applies to you as well in some ways. So this is a story I hear very often. This is the assistant professor. She's 5 years out of fellowship. She's an excellent clinician and teacher, has won teaching awards from the residents. She has 2 children with a working spouse. She does 16 weeks of daytime service and 28 night calls, which is 4 weeks of nighttime service in-house. And she's due for her promotion to be an associate professor, and it's overdue. The paperwork was due on June 30th. It's already 2 months late. And then she meets with the chief and the chair, and the chair and the chief point out that she has no first author publications, and I wish you had 2 first author publications. Sound familiar? And I have her salary numbers here for whatever that's worth, and if she gets promoted, she'll get a decent bump in salary. She finishes a hard week of service with inadequate NNP or PA coverage, or resident coverage. She had to see many patients herself, and then she's driving back home really tired. And then there comes a phone call. So she picks up the phone. It's from one of her former fellows. And the fellow says, hey, there's a really interesting job in my community. It's a small community level 2/3 NICU, and it provides you with a really good salary. All you need to do is 7 24-hour calls per month, and then you can do whatever you want. You can even take these 7 calls continuously and be done with it. And the salary, of course, is much higher than an academic salary. It's very tempting. It's tempting not because of the salary issue. So this is not the main attraction here. It's the level of flexibility that she gets with her time and ability to spend more time with the family that's more attractive here. So that's where we are. So I told you I've been an academic neonatologist. I borrowed this slide from Gil, who showed it a couple days back. And things have changed a lot in the NICU between 1980s and 90s when I was a resident and a fellow to what's happening now. In addition to the technology, what I have seen is that in the past, I could round very easily on nearly 60 patients. The residents were really good. They would round. All I had to do was sign on a paper sheet. There was no cut and paste because it was not EMR. They had to write something, and then I would read it and then sign it, and then that was it. And believe it or not, I was really happy. And there were days when I could be on service and go to the lab, take care of a lab experiment, and come back and sign out. So this was the flexibility I had as a academic university-based faculty member. Things have changed. The charting is a problem. Complexity is an issue. We have 22 weekers, many patients surviving with complex illnesses, and chronicity has increased. Lauren talked about having babies spending their first birthday in the NICU. That's not uncommon. We are seeing babies that are much older, and this has led to a lot of angst to be on service, and it's difficult to be on service for more than a week. I used to do 6 weeks of service at a stretch, and now doing a week itself is taxing. So changing work expectations, both the clinical work expectations and the non-clinical work expectations, are really taxing academic neonatologists. Among all pediatric subspecialists, the percentage of neonatal faculty in academics devoting their career to research has gone down. It's only around 35% compared to nearly 55% in other specialties. There are issues about gender equity I will talk to you about, and there are unsustainable productivity thresholds that we need to meet, and there's a nationwide shortage of neonatal PAs and neonatal nurse practitioners. But the thing that's really stressing is the fact that academics expects everybody to be a quadruple threat. And Dr. Narvi told us day before yesterday that it's actually a quintuple threat. There's a fifth threat, knowledge transition as well. So it's not good enough if you're a teacher and a clinician. They want you to write papers. They want you to do administration work. They want also to spread knowledge. And this is becoming unsustainable for one single person. And as you know, pediatrics as a department, which was a painful realization to me as a chair, typically doesn't make money. And there's a lot of pressure on neonatologists to generate enough money to make sure the department stays afloat. And more interestingly, the expectations for work between academic and non-academicians is slowly dwindling away, but there's a huge gap in salary, and that's where the stress is coming from. So if you think of an academic or a university-based neonatologist, their workload has gradually gone up over the years and has changed quite a bit, and there is reduced access to trainees, and it's not as much fun as it used to be anymore. That has led to decreased engagement. On the other hand, on the non-university-based or private practice model, the salary is a bit better, but the productivity benchmarks are slightly lower. There is considerable flexibility in schedule, which really matters to many people. And you can no longer call this group as non-academic because many of them do a phenomenal job. For example, there are lots of papers coming out in New England Journal of Medicine using the pediatrics database, which is really, really important. And several quote-unquote non-university-based faculty do a great job teaching. I'm just taking the incubator, for example. More number of people in the world learn from listening to the incubator than any one of us can do a journal club for that matter. I listened to the journal club this morning from September 15th. So informative. And that's the beauty of non-academic work right now, so-called non-academic work. So the difference between these two workforces is gradually disappearing away. And for that reason, for some reason, there is increased burnout, reduced engagement, and increased transfer of faculty towards the non-university-based model. In fact, neonatology is the largest subspecialty among pediatric subspecialties within the American Board of Pediatrics. And interestingly, neonatology also has the least number of full-time academic faculty among all pediatric subspecialties. It's around 40.8%, compared to over 62% in PICU, which is our closest related field. And full-time cardiology appointments are nearly 65%. So we are the field where there is reduced academic professionals, and there's increased transfer to a non-academic area because of the various reasons I mentioned. So why is this important? This is important because academic physicians, as I told you earlier, have one important role, that's mentoring fellows. Nurturing the future breed of neonatologists is the most important thing that we do. And if you look at what's happening with pediatric subspecialties in general in this country, it's very concerning. As a chair, it's hard for me to recruit many pediatric subspecialists. It takes years to recruit. The wait list for somebody from genetics, as Pankaj was talking earlier, is nearly 12 to 18 months to get an appointment. And I list out these 8 specialties on the top. I call them the reading specialties. That's pneumonic, rheumatology, endocrinology, child abuse, et cetera. They are not filling their limited fellowship slots. The unfilled slots in NRMP range anywhere from 40% to 60% for genetics. So the focus has been on this. But come back to neonatology below at the bottom. We used to have only 2.8% of seats went unfilled in 2001. The number jumped to 6.9 the next year. Last year it was 11.3%. These numbers are doubling or doubling every year. And part of the reason is that we don't have happy, cheerful role models in academic medicine to attract more trainees to come and join neonatology. The second issue is that we have hospital medicine, which is a new fellowship, which is attracting a lot of fellows. Those who are planning on doing neonatology are being diverted away to seek further career in hospitalist medicine. And then here comes ACGME changes that come in next year. As many of you have heard, now ACGME is recommending a total of minimum of 12 weeks of ICU rotations throughout the whole fellowship and a minimum of 4 weeks of rotation throughout in the NICU for the whole 3 years of fellowship. And that will further decrease interaction between a neonatologist and a pediatric resident and decrease the pipeline for neonatal fellowship. So why are people not going to these fellowships in pediatrics? As many of you know, pediatric residency match last year was a disaster. We had so many unfilled seats in pediatrics last year. And part of the reason is that the payment or salary for pediatric subspecialists in this country is very low. This is a complex graph. This is the only complex graph I have, but I will walk you through this. So what you have on the horizontal axis is percentage of adult compensation or productivity. So this dark red line is 100% of adult productivity, which is in dark black bars, and the gray bars are productivity, and the dark bars are salary. So as you can see, for example, we had a nephrologist speak to us the other day. A pediatric nephrologist only earns somewhere around 80% of an adult nephrologist, but their productivity is also low. Their productivity is roughly around 50% of an adult nephrologist. So their productivity is low, their salary is low. In sharp contrast, once you move away from the Department of Pediatrics, we heard from a pediatric surgeon yesterday, pediatric surgery, although their productivity is low, their salaries are fairly high because of their rigorous fellowship and the tight market that they control due to very few fellowships in this country. As you can see this graph, there is one striking outlier, and that is neonatology. Our productivity is twice that of a pulmonary critical care adult person, but our salary is around 80% of that of an adult critical care person. And this is a real anomaly. And the reason why there has to be so much of productivity in academic neonatology is because we need to sustain the whole Department of Pediatrics and support the Department of Pediatrics in one way or the other. So when we started staying in-house in many academic NICUs, I thought gradually our benchmarks for academic pediatrics, academic neonatology will start coming down. And I was right until COVID. And then God knows what happened. Last year, all our benchmarks, as you can see from this graph, went up. And the bottom line is the AAAP numbers. The top line is the CPSC, another type of benchmark. And so when you compare benchmarks between 3 inpatient pediatric subspecialties, there's a wide variation. Pediatric hospitalists are supposed to generate 2,500 work RVUs per year. Pediatric critical care is supposed to generate 5,500, whereas we are supposed to generate nearly 12,000 work RVUs per year, which is twice that of PQ, almost 4 to 5 times that of a hospitalist. And look at my own department. This is my department at UC Davis. And the NICU brings in close to 31% of revenue for the Department of Pediatrics. And when I pay out salaries and benefits to my faculty, only 12% of the revenue goes to the neonatology division. Whereas compare PQ, PQ matches quite well. 18% is brought in, 17% is taken out. But neonatology partly bears the burden of many other specialties. This graph might look different in different academic practices. There are some practices that have very prominent hem-onc divisions, cardiology, et cetera, but this is how it looks in my own department. Okay, enough of despair. Let's talk about what the solutions are. How can we increase engagement and reduce burnout among academic clinical faculty? So to address this, a lot of very smart pediatricians in the country got together, and this book came out. This is a report by the National Academies of Sciences, Engineering, and Medicine. This is called NASM. This is a beautiful 360-page read. It's a free download, and I recommend strongly that all of you download it before you get on the plane and read it on your way back. It's a very interesting read. It talks about what the difficulties are being faced by pediatrics in this country, and it's a really important one. And I summarized this whole 360 pages in this infographic. The bottom line is that there have to be changes in education, there have to be changes in how research is supported, but most importantly, there needs to be congressional action to fix Medicaid in this country, because many of us care for 50 to 70% of patients in our NICU are paid by Medicaid, and in many states, that reimbursement is very, very low, and that has to be fixed. But interestingly, this book hardly talks about our field. There is nothing about academic neonatologists in this book because all they mention is that academic neonatologists have reasonable salary and they're not really mentioned, but that's not the focus of this book. This book is mainly meant to address outpatient specialties, the reading mnemonic I showed you earlier. So we need three things to fix and improve academic neonatology in this country. Number one, we need more transparency. All of us, whether we work in academic settings or non-academic settings, we work quite a bit. And not only our clinical work, but non-clinical work also should be recognized. For example, if you set up a POCUS program like what Lauren was suggesting, it takes a lot of time and effort to set up a program like that. That work should be recognized and should be rewarded, and also there should be reduction in time for that. So this is this model called as 1- model, also called as the CARTS model or CARES model. What it means is that your whole FTE is like a pie. That's 1.0. And then everything you do, for example, you do service, you do education, you do research that's funded, you do administrative work, you do work on equity and diversity. All this is subtracted from the 1, and when you subtract all this, you land up with like 0.5 or 0.6 or 0.8, whatever it is in your situation. That's your clinical load, and your clinical load should be based on that. So having transparency, clearly showing what every faculty member in the division is doing is very helpful. The second thing is, within the 16 divisions of pediatrics in my department, there is considerable variation in work hour expectations. This is a survey that was done nationally way back from 2004, 2005. And what it shows that just within neonatology, there is 1,000 hours per year difference in the amount of work done by a pediatric emergency medicine physician compared to a neonatologist. That's the degree of variation that was experienced in 2004. But these numbers are changing and things are looking better. But still, even today, when you look at the MOCA surveys that we all fill out when we take our MOCA recertification exam, you look at neonatology predominantly is working anywhere from 40 to more than 60 hours per week, whereas PEDS EM is predominantly working somewhere between 30 to 50 hours per week. There's a distinct difference in the number of hours we work based on the surveys we fill out. So the argument is that should the total hours worked be similar across all specialties? I mean, if you assume there are 52 days, 52 weeks in a year, you subtract time for vacation, CME, holidays, et cetera, you'll end up with 44 weeks. We work 45 hours a week, so it's around 2,000 hours per year. And then you take some time down for administration and teaching and mentoring, and you'll end up with somewhere around 1,650 to 1,700 hours per year. Should this number be the same across all subspecialties? Should an ID doc be working the same number of hours as a neonatologist? I would argue yes. I mean, we are all physicians. As long as we are staying in-house, the hours should be the same. And of course, if you're working on a Christmas night, there should be some hazard pay or some pay differential for working on a night where you would have much rather spend some time with your family. So that variation also exists. There are lots of groups currently working on this. It's led by a group, many people from the Women in Neonatology group, the WIN group, are working on this particular issue. And the whole idea is to bring the total number of number of work hours per year for both academic and non-academic neonatologists to a reasonable number. And when you look at different models as to how long people work in an outpatient setup, it's around 8 to 9 clinics per week, and that turns out to be around 1,683 hours per year. When you look at inpatient models, somewhere it turns out to be roughly that. So my recommendation as a chair is for all my faculty to approximately work around 1,650 clinical hours per year after subtracting some time for administration and teaching that's considered to be standard expectation for all people. The third issue that needs to be addressed is gender equity. I am a husband. My wife is an adult cardiologist who works at the VA. My daughter is an internal medicine resident in San Francisco. And I see all my colleagues around me, and there is so much of gender discrimination that happens in hospitals and medical field right now. As we look at the data right now, 3/4 of neonatal fellows today are women. And they are smarter than us dinosaurs. They know how to work smarter, which is something we had no work-life balance, but things are getting better in neonatology. And we really have a need to optimize work hours. There is also unequal distribution of tasks in many divisions that I openly see, like women are asked to do many undesirable tasks compared to men. There is this difference that exists everywhere. And the last thing that really bothers me is, of course, the factor about money. Any field where there are more female providers, there's a gradual reduction in the amount of compensation that happens in that field that happens automatically, and I can't understand why. If you don't believe me, look at this graph. This is a simple graph of all internal medicine subspecialties. And what you have on the y-axis is percentage of these fellows, first-year fellows, who are women. The highest paid specialties are down at the bottom: cardiology, EP, interventional cardiology. They're all men. Less than 10 to 20% of these fellows are women. The least paid internal medicine specialties are endocrinology and geriatrics. There, 70 to 80% of these fellows are women. This is a really odd phenomenon that's seen in many different fields. And the thing I really don't want to happen is that with increased number of female neonatologists, we really don't want salaries to go down in neonatology. That's something that we should be very carefully watching for and prevent gender inequity entering into our field. So Chris Bishop, who is a phenomenal neonatologist, she wrote this paper with many authors from the WIN group, and I urge you to take a quick look at it because it has a lot of other solutions. AI could be a solution for writing notes. Funds flow is an approach where the department or the health system supports all departments through a central mechanism. Improved coding is really important as well. But the bottom line is this. So there are two entities that we deal with. One is money, and the second is time. And we need to come up with a way to optimize the amount of compensation that we give and reduce the workload and optimize both of these things. So what we need is a reduction in the number of clinical hours to a reasonable number similar to all other subspecialties. We need a slight increase in compensation to meet the amount of money that academic neonatology brings into the department. And third, we need a slight reduction in work RVUs, and more importantly, we need flexibility. Flexibility is really key. It's no longer appropriate for every person to excel in all fields. It's impossible for a person to be a quintuple threat all the time. If we have an excellent clinician, an excellent bedside teacher, that is the role model that a resident is looking for to enter into the field of neonatology, and that person should be supported. So my request to all academic leaders, many chiefs, chairs, deans, and CEOs, is to be flexible with academic neonatologists, in fact, academic all clinicians, and adapt to the changing circumstances that are happening right now, improvise how we work, and more importantly, give recognition to clinician-educators that are among us. There is often this increased preference. Like why did I become a chief? Honest to God, I became a chief not because I have any administrative skills, but because I had an R01. So what does R01 teach me to be an administrator? Zero. So this increased importance to research is important. Research is important, don't get me wrong. I've been a researcher all my life. At the same token, clinician educators should also be recognized. I will end you with three thought-provoking thoughts. The question is, when pediatrics formed a department like almost 50 years ago in many places, internal medicine people thought, why the heck do you need a separate department for pediatrics? But today in this country, there are approximately 5,300 neonatologists. Though for those of you from a university, how many of you have a department of neurosurgery? I bet many of you do. And there are only 3,800 neurosurgeons in this country, and I can guarantee you, if you go to any university in this country, there are more faculty in the division of neonatology compared to the department of neurosurgery. So it's quite likely that we need a department of our own. The second thing, we are struggling to figure out what to do with neonatal medicine fellowships, because every single pediatric fellowship is 3 years, and there's a discussion as to whether it should be shortened to 2 years. What we feel is that that's not something that will work, especially when the incoming fellows have only 4 weeks of expertise during their residency. That will not work. What is a better solution is to follow the example of pediatric neurology, do either 1 or 2 years of pediatric fellowship, and jump into a nice long 4-year fellowship in neonatology, and combine these two for a total period of 5 years so that people can come out and start earning an attending salary as soon as they can. And the last thing we need is an association. And I also hate the word neonatologist. And it's not even neonatal intensivist. We are critical care providers, just like adult critical care providers, just like pediatric critical care providers. We are neonatal critical care providers. And I believe we need an association or something to represent our goals much better. These are 3 thought-provoking talks. And I thank the AI people for helping me figure out how to make this graphic here for the association. But that's where I would like to start assisting you to start thinking about how should we look at neonatology in the future? What should we do to enhance the pipeline into neonatology? And think outside the box to sustain our own field. Thank you very much.